My name is Benjamin Greenberg. I direct the Transverse Myelitis Center down at the University of Texas Southwestern. Although my upbringing and training and early career started at Hopkins, and I miss my colleagues and friends there dearly all the time, I always enjoy being invited back, even virtually, to take part in different conferences. Carlos had asked me at the end of today's session to talk about putting the pieces together, looking at a patient from admission to discharge. And I wanted to zoom this out and really talk about this at a high level. While this is not a CME event, I always give disclosures about the different organizations and companies I work with. And most critical to this, I am an unpaid member of the board of the Siegel Rare Neuroimmune Association that has worked so hard on behalf of AFM patients and families. But when we look at the symposium thus far and what we're going to hear in the upcoming weeks, and it's really been a spectacular lineup of speakers and topics. We've talked about acute flaccid myelitis, the disease. We've talked about the epidemiology of acute flaccid myelitis at a population level. Importantly, incorporating the perspectives of patients and parents who have been incredible in educating me about this condition and my colleagues, and incredibly giving of their time, their energy, and their perspectives and their data, and sometimes even their blood, in order to help the greater good sort out this condition. We've talked some and will in the coming weeks talk about the virus. So much time is spent trying to understand the biology of this virus, and it is critical to understanding the disease. But often neurologists go through their training not thinking about the basic virology of things, and yet with this condition we've had to. We've spent a lot of time talking about differential diagnosis, and last week there were talks relative to recognizing this condition. The imaging plays a role. We've heard about the electrophysiology today, and we've heard about MRI in the past. And then the natural history, trying to understand at a population level what happens to individuals and who has had this condition and what happens in the days, weeks, months, and years after being affected. Today, there were a lot of discussions on the ICU management, whether it's mobility in the ICU or the respiratory management of patients who are critically ill with this condition. And then we focus on rehabilitation. And there are going to be discussions in the coming weeks about which rehabilitation strategies have been used to help improve. And so at a high level, the symposium is talking about all of these different pieces in nice individual boxes and categories. But when we put the pieces together, we really think about the single patient experience, and we ask the 5 questions that journalists get trained to ask, which is the who, what, how, when, and why questions. And if you apply these questions to each of the pieces we discussed, it'll lay out for you the roadmap of what do we need to do to solve these problems. And so if you start with the very simple notion that there are viruses that circulate, and frankly, our population has now become experts in the notion of circulating viruses, unfortunately, due to the coronavirus outbreak. And we have raised the level of understanding and awareness of viruses, virology, and viral ecology in the United States by undergoing the coronavirus pandemic. But we know that viruses circulate, and only some people will become infected. This is a point where there are questions being asked. Who becomes infected? When do they become infected? Why is it some people and not others? How does the infection take place? Why does this virus, when exposed to this person, lead to an infection versus not? And what is the implication for the infection? And just with this simple, very basic piece of what's being talked about in the symposium, a virus circulating and infecting some individuals, there is a host of questions that could be asked, and entire careers spent understanding the 5 questions around a viral infection. But it gets more complicated as we follow the patient through their experience. Some of the individuals who become infected will have respiratory symptoms, but not all. When we talk to families who've been affected by acute flaccid myelitis, most have had some sort of prodromal illness, usually a respiratory infection, but often it can be a GI illness or very non-specific symptoms like a fever. So while some people have respiratory symptoms, not all. And understanding the why and the how and the what is incredibly important to understanding the pathogenesis of this virus within an individual. But then comes the big set of questions for the community we serve. and that is the development of acute flaccid myelitis. There's not a week that goes by that I don't get asked the question, why did my child or why did I develop acute flaccid myelitis when the entire family was sick with the same virus? And there are a series of questions being asked, the who, what, how, why, and when questions of, are there changes in the virus within one individual that leads to the acute flaccid myelitis phenotype? Or are there specific features of a host that make them more susceptible to having damage from the virus? And in addition, there is the who, what, how, why, and when questions of what actually causes the damage. How much of it is caused by the virus itself? How much of it is caused by an immune response to the virus? And what are the number and variety of viruses that can lead to the same phenotype? So there is a lot of work being done at this level of some individuals developing AFM. But today we talked about, and last week we talked about the patient experience once the symptoms have begun. And we're all painfully aware of the issues around getting a rapid, accurate diagnosis. Some people will be diagnosed quickly and accurately, others will not. And that delay in diagnosis can have implications both for missed opportunities to treat a condition, as well as potential exposures to treatments or therapies that may not be indicated for an individual with acute flaccid myelitis. And so getting an accurate early diagnosis is always critical for our patients. And then comes the variability. And I'm going to spend some time on this in a moment, but as we've talked throughout last week and this week about the different phenotypes that AFM patients can have, upper extremity, lower extremity, respiratory involvement, different patterns on electrophysiology that Matthew just discussed. The idea that some patients will have a reversible sick motor neuron while others will have motor neuron death, leading to more severe symptoms. Within this category, there are the who, what, how, why, when questions that we can spend a lot of time focusing on as to why some people have more severe AFM presentations and experiences than others. And we look then to outcomes, and we look at outcomes on the short term and the long term. We have some kids who are quite ill early on who in the very short term show gains in one or more limbs. And then we have individuals who show little to no gains. And within the same patient, different limbs can have wildly different responses to therapy and or just natural history in terms of how they recover. And so there's a lot to be understood relative to those short-term outcomes. And then ultimately, it's the long-term outcomes that we focus on. We want all of our kids to get back to full functionality in the short term, but at a minimum in the long term. And at each of these points in the different pieces we deal with, there are all 5 questions that could be asked. And there are needs across the entire spectrum of the patient experience relative to research endeavors to both ask and answer these questions. So what would I, after listening to all the talks and knowing the talks that are going to come up over the next couple of weeks, how would I list the current state of needs for the acute flaccid myelitis patient population? So it's important to break this down into 2 categories. We have to talk about future patients versus existing patients. And the needs of these 2 populations are different. But it's extremely important to recognize that future patients don't know they have needs yet. It is only our current patient population and the current population of clinicians and scientists who recognize that they are going to have needs. They don't know that this unwelcome guest is going to affect their loved one yet. So we have a fiduciary responsibility to start working and continue working to meet the needs of future patients. And what are these needs? So the first is around rapid diagnostics, being able to get patients who are yet to show up a fast, accurate diagnosis of acute flaccid myelitis. We need acute treatment protocols. Once the patient is diagnosed, what does the evidence say? What evidence do we need to gather in order to guide clinicians on the appropriate way to diagnose and then treat patients with acute flaccid myelitis? And then ultimately, we have a fiduciary role to determine whether or not this is a preventable illness, whether it's through vaccine development or other mechanisms, as we learned in coronavirus. Social distancing, hand washing, wearing masks makes a difference. there's every reason to believe that those efforts may make a difference relative to the enterovirus circulation and acute flaccid myelitis. But we also have a current state of needs among patients and families who have been affected in the past by acute flaccid myelitis. And these include critical conversations about the approach to rehabilitation, something that has been discussed within the symposium so far and will be discussed in the weeks ahead. And we've had discussions about the notion of augmented recovery. Can we use technology? Can we use surgical procedures? Can we use interventions to promote recovery even beyond the natural healing process that different patients have? And then we have needs for psychosocial support. And it is going to come up, I think, towards the end of the symposium in the last week, the holistic approach to caring for our patients, not just their neurologic needs. What I'd like to do is break these two populations down and just speak to each one independently for a moment, starting with the future patients. And when we look at the future patients and we talk about diagnostics, the first step is awareness. We've partnered with the Centers for Disease Control. We've partnered with the AFM working group and with the Siegel Rare Neuroimmune Association to do our part to raise awareness amongst clinicians on the front line relative to being able to recognize this condition and then appropriately test patients in the setting of possible acute flaccid myelitis. We've talked about education programs, not just being aware that AFM is an entity that's out there, but giving targeted education to clinicians in order to improve the care patients are getting. And then there are needs for resources and tools. We need better viral diagnostics, the ability to identify the virus in individuals as they're coming down with symptoms of acute flaccid myelitis. And we need better diagnostics to prove that motor neurons are being killed. We heard about the challenges of doing electrophysiology in pediatric populations and also challenges in getting MRIs. Finding ways to rapidly identify somebody with injury to their neurons would be a big help. So there's public awareness education programs that are needed, but also resources. Therapeutically, we have definite needs. First, we need an outcomes database nationally amongst all patients relative to the treatments they got to try and understand what's working and what's not. And then we also need to understand the pathobiology. And in the last talk about electrophysiology, I was thrilled to hear the introduction of this notion by Matthew of a reversible sick neuron, something that's been talked about for many decades. And understanding the pathobiology of how much of neuronal death is mediated by a virus versus an immune response makes a big difference to picking therapeutics. In some cases, we will need antivirals in order to shut down viral replication. But in other cases, we may need anti-inflammatory agents to prevent the immune response to the virus or the effects of the virus. So understanding at a basic science level how and why this virus leads to the damage it does makes a big difference for our therapeutic interventions. And then finally, for our future patients, there's prevention. And as I mentioned, we need the pathobiology studies to understand which virus. Is it all enterovirus D68 viruses or just some of them that can lead to this phenotype? And then translate that into preventing infection, either by doing the social distancing, hand washing, and masks that we currently use, or do we work on vaccine development? And so these are big questions and big needs. And as you can imagine, each of these take a lot of resources. But if we shift gears and do a high-level review and put the pieces together of what are the needs for our current patients, they fall into three categories. During the symposium, we've talked about rehabilitation relative to time course, acute, subacute, long-term rehabilitation needs. And in today's session, there was the discussions of mobility in the ICU and what can we do early. Outcomes relative to intervention intensity. We need to prove to us, to families, and unfortunately to third-party payers that more frequent rehabilitation, whether it's done with a physical therapist or done by the individual with their family, just the intensity of the rehabilitation makes a difference relative to outcome. And then the outcomes relative to intervention type. There are lots of different ways to go about rehabilitation. You'll hear about some of them in the coming weeks, but we need to come up with a standard of what should therapists be doing to deal with both the lower motor neuron and potential upper motor neuron patterns of weakness that our patients have. Some patients have the flaccid limb that's become atrophic, and some have tightness and spasticity, and they need to be managed differently. And there need to be clear guidelines and clear outlines of how to do this. Within those intervention types, we also talk about electrical stimulation and functional electrical stimulation. We talk about exercises and aquatherapy, and knowing which of these to apply to which patient, when, and how is critical. Not everybody can get on a plane and make it to Kennedy Krieger, but we need to validate what works and what doesn't from Kennedy Krieger and elsewhere, and then put it into a global recommendation of how to approach these patients. And then we get to augmented recovery, something that we are very interested in and actively pursue here at UT and in Baltimore, at WashU, in Philadelphia, and a variety of other centers. And there are several different versions. The one that a lot of people talk about for the future is stem cell development. Is there a way to implant a new motor neuron into the spinal cord, have it grow out to a muscle, and restore function? And the answer is, in an animal, yes. We just have to translate that to a human endeavor, and there are many individuals working on this. But beyond or before being able to implant a cell into the spinal cord, there's also the nerve transfer surgeries that many families have either considered or undergone. And obviously, we need to understand what muscle targets are most amenable to such a procedure. And one of the most controversial issues is around timing. What is the optimal window for performing one of these nerve transfer surgeries? And then finally, psychosocial support relative to our current patients. We need to be supporting the patient, the family, and the community as our kiddos, despite their illnesses or whatever symptoms linger or deficits linger, we want them back in school. We want them back with their friends, back in their community. But often there is a level of support, whether around the educational or the emotional aspects, that need to be addressed. And later in the symposium, you'll hear from Dr. Harder specifically about some of these topics. So how do we decide priorities? I just listed a lot of different efforts that would be needed and a lot of different work that could be done. And there's limited time and limited resources. And so when thinking about it all, I'll present my personal opinion about where the priorities lie. First, the priorities for future patients, not more important than the current patients, but within their needs, immediately, I think we need to work on improving recognition of this condition and sorting out what acute therapy protocols actually make a difference or not for our patient outcomes. Long-term, my personal opinion is we will be doing our duty if we explore the development of a vaccine to prevent this from happening to anyone and decide who amongst us needs the vaccine or does it need to be distributed to everybody. Among current or existing patients, the immediate priorities I would define would be rehabilitation approaches and the nerve transfer data collection. And then long-term, I think we do need to make the investment in the stem cell development. And in the meantime, these two talk to each other. So sorting out rehabilitation approaches to try and maintain muscle health will set patients up to being outstanding recipients or candidates for a stem cell therapy of the future. So out of all the different things we could be focusing on, if I had to distill priorities when putting it together from start to finish, these would be the ones I would personally prioritize. So how do we get it done? So you need stakeholders, and this group represents on this symposium and in the audience and amongst the speakers, a great representation of the stakeholders. It includes patients and families who play a critical role, clinicians treating the patients, public health officials helping us with the data and education, and basic scientists doing the work. And you have to bring them together in a meaningful way and in a collaborative way to get the job done. And the way you promote success is first through advocacy. It is hard, if not impossible, to underestimate the role of patients and families who have been through this in getting this job done. So they play a role in targeting other patients to become active. It is not unusual for us to have patients who have had significant or full recoveries treat AFM like a bad dream and move on with their life, which I'm thrilled to witness and hear about. But we need their involvement in order to understand the full 360-degree representation of this disease. So we need other families to engage with them and keep them engaged and working with us. We need advocacy from patients and families to target clinicians and government officials in order to design and execute the educational programs, the funding, and the research that is needed to move forward. But we need resources for organized efforts. So looking for opportunities to partner. So this is where the Siegel Rare Neuroimmune Association has played a great role of partnering up between a variety of patient populations in order to achieve greater success for the entire community. And then finally, we can only get there through sacrifice and dedication. We ask our patients' families to do a lot. We ask them to care for their loved ones, to do physical therapy, to make it to appointments, to juggle insurance, to juggle appointments. And then on top of that, sign a consent form and take part in research. And I am perpetually in awe and thankful for the incredible work our patients and families do. But that's what promotes success. Unfortunately, a lot of the burden falls to those who already have a lot on their plate to help push the entire stakeholder community forward to try and get those priorities taken care of. So in the end, when we're putting the pieces together, whether we're talking about the virus itself or we're talking about why people become infected versus others, why certain people have AFM, and what are the outcomes, with each of these having a lot of questions to be asked, this is something we can achieve. This is something we can have success in. And those successes are going to be defined in each of the individual buckets. We may have successes relative to the virus before we have successes for long-term outcomes. And so our different constituencies of future and current patients may achieve success of their addressing of the priorities at a different rate, but we still have the obligations across the board. And so it's through efforts like this, and I congratulate my colleagues at Hopkins for putting together just such a beautiful symposium. I'm sorry we're not all together in person, but I am thrilled that they were able to carry this on even virtually, and it's been wonderfully educational. So with that, I'll end with the before and after of my daughters, before my move to Dallas and after my move to Dallas. And I remain thankful every day that they are healthy and have not been affected by acute flaccid myelitis or any of the conditions I treat, and can only imagine what it's like for families to go through this. But I'm thankful for the institutions, the organization, and the families that work with us to try and find answers. So with that, we'll be bringing the lecture part of today to a close, but we will be opening up the panel discussion so that we can answer the questions you have. So at this time, what you are supposed to do is to click the sessions button, which should be on the left hand of your screen. It will take you out of the stage area and into the panel discussion where we can answer your questions. I appreciate everyone's attention and look forward to seeing you on the panel side of things.